Hello, everyone, and welcome to this next episode of the Akal and Koka Report. We are delighted to have back on the show Dr. Anupam Singh. Dr. Singh was a guest early on, maybe 2 years ago, one of our first episodes, giving us a perspective on evidence-based medicine, India style. But now we're going to talk about COVID, of course, and we are very excited to hear what's going on in India from Anupam. Anupam is an assistant professor of medicine at the Santosh Medical College in Ghaziabad in Uttar Pradesh, which is close to Delhi. And Anupam, welcome to the show.
Thank you. Thanks for having me.
How are things going?
In India, as of now, we have like 20,000 cases, 20,000 odd cases right now. So as compared to what was expected, given our high population density and everything, things are okay. Things are going in arithmetic progression around 1,000 cases a day till now.
It's right. It seems amazing. And how confident are you? I mean, because people talk about perhaps that you're not finding all these patients or lack of testing, but one way or another, it will be reflected in the hospitals, right? If there were missing cases, what are your thoughts on that?
So there are two things. The criticism, the lack of testing has been there, but our test positivity rate is low, right? It's around 4.5% only. So that is the thing, which is reassuring. Number one, because we have expanded the test. We have done 500,000 tests till now, which is still lesser compared to, say, NYCT or Italy, but it is reassuring. I think the major cause is we started, it had a cost. We started lockdown pretty early. At 600 cases, India started a lockdown and at 10 deaths.
So time-wise, when was that, calendar-wise?
So it was, the lockdown was done, the central lockdown was done on 23rd of March. Okay. That is almost a month back. So that has perhaps led to, slightly flattening of the curve, and it gave us some time. So now the cases have, jumped up to 1,000 cases per day, but I think that reflects in some of the results we are getting. In addition, I think some amount of weather and possible immunity factor, there is a possibility might come into play, though it's still a hypothesis.
So the lockdown was for the entire country of India?
Yes. So this is how things, have evolved in India. In early, around 30th of Jan, when we heard about the cases, India started to bring its students back from Wuhan, China, and many Wuhan. We brought them and quarantined them near Delhi. We checked them all. Around 1st of March, we started screening all international travelers. We were already screening people from China, but we started screening all international travelers.
How are you screening them?
We were doing routine thermal screening and quarantining them since around 2nd or 3rd of March.
Do you know how many people were screened positive, and how many people were being quarantined?
Okay, so I don't have the data right now, but we were essentially initially screening all the people from select countries and quarantining them from China, Thailand, and then we expanded the criteria from Dubai around 11th, 14th March, and we included patients from US and Europe also when US declared an emergency on 13th of March, I think, yes.
And again, to be clear, the quarantine would be only in people who had the temperature or who had the positive test, or it was just as a matter of course?
Based on temperature. We did temperature screening and we advised them home isolation. It was a mix of, it was a home quarantine, not a...
And it was a voluntary home quarantine. It wasn't cell phone based, app based, nothing.
No, it was nothing of.
And then Europe, however, there was no ban until when was the Europe ban instituted?
Around 13th of March, when we started seeing a lot of cases from, there was a US emergency, probably Trump announced the same, and we are seeing a lot of Italy numbers shoot up. So that is why we were late. We actually, did a good job with China thing, but we were not aware, our initial surge was from patients from Dubai, which was transit from, Europe, and Italy, and UK. So these were our initial numbers were coming from there. And there was a, special cluster of Tablighi Jamaat. It is a special, it is a community, evangelist community, which is, focused in Southeast Asia. It has led to a spreading event in Indonesia, Pakistan as well. So we actually, missed out on this cluster, which had led to, almost 1/3, 1/5 of cases now are from this cluster.
Right. But again, it sounds like really the awareness in India of how much this was spreading, of the kind of the pandemic nature of this, also kind of occurred after the Italy experience, right? After Bergamo and Lombardy, that region kind of exploded, and all of us together saw that. Then about a few weeks later, the U.S. declared U.S. started ramping up its things, declared emergency at sometime mid-March. It was pretty obvious. I think March, I think 15th or so is when, around there, I'm getting maybe off by a few days, is when things really got intense in terms of saying, all right, it's likely that this is spread here. But the point is that none of us, it doesn't seem like anyone had a sense prior to mid-March that Italy was an epicenter that was probably spreading stuff all over, or from Europe.
India, actually, we started at end of Feb. We started, seeing these things, and it was, the discussion was pretty wide. Almost the Italy numbers were shooting around this time. So we started screening, as well as there is an interesting innovation also. You couldn't make a call in India without listening to caller tune about coronavirus, and it was an advisory. I mean, it was an innovation of the sort. You couldn't call. You had to hear this 1 minute of info. That information around. You have to take precautions regarding coronavirus. So while you didn't have mask, people were applying all that sort of clothes over their noses and etc. Though the initial. But the main, the executive action started around 15th of March.
Right.
14th of March.
And you had a cluster of travelers from Italy, right? Yes, I remember the initial cases, the first cases, or one of the early cases in
mainly from Italy and
Dubai.
Italy.
You were tourists from Italy, correct?
Yes. We had travelers from Italy, and in fact, initial 1,000 cases, a lot of cases from Italy, Dubai, UK. These were our major, chunks, not from China.
Right.
And then,
so now, did India have testing capability in mid-March? The RNA, the PCR test in mid-March, or when did that come?
So we did no. So what happened initially? The government took everything on itself. That is the story. I mean, that I see everywhere around the world. So, but we, collaborated with private labs around, 14th of March, and we allowed few labs which were, in partnership with Germany. And initially, they started, getting a lot of tests. And even now, you have only, I think, 20-30% of the tests are done in private labs. Also, so it has not expanded, but we have like 10 or 12 companies in fray. Many Indian-based companies have also, started getting into the act. We have few countries which do rapid PCRs. We were actually having that capability we were using for TB resistance, the Cepheid test, the Gene Expert. So we had these portable point of care PCRs. So we had a culture of them. And few Indian companies were into that also. But we had to import the primers. The primers, we had to import them. The extraction kits initially were in short supply. As the numbers went up, we imported quite a lot of them. So now we are doing almost 40,000 to 50,000 tests a day, which is still less. But the lockdown has bought us some time. Now the infrastructure is in place, though at some places it is still low. India also capped the PCR, cost for private labs at around $60. So a lot of labs, for example, if I want to get a test in this hospital I've been testing, I have that, the levity. I have that. I should do it again.
Do they run it on site? It's on site that you do the test?
No. We don't have that. Okay, so I have not got this. Ideally, the TrueNat, that is the portable point of care PCR, that is only a screening test. It doesn't confirm for this thing because the machines are a bit costly. In Indian rupees, they cost around 10 to 12 lakhs. So even the Cepheid one costs around 20 to 25 lakhs in Indian rupees. So these are not available to me. I get people come from sample collection centers from the PCR company. They do, and the turnover time is around 12 to 24 hours. So this is currently, but we are, in the people have ordered for the Abbott machines. But right now, what is happening is every country is caught up in its own. So big PCR machines are probably imported at some places, but they are not very, the point of care PCR machines are not very common as of now. Obviously, it will change as time evolves. Recently, we procured some antibody kits, around 10 lakhs of them. So, but I mean, they are more for surveillance purposes in high prevalence hotspots.
Okay.
And India has, integrated sort of a diagnostic and management strategy. The antibody tests have been, integrated in it. But there are some validation issues. We bought them from China and South Korea, but there are some validation issues around it. I mean, the details are not clear, but people were telling the sensitivity is low. Obviously, we are not using, because initially our ICMR, the CDC equivalent of India, so they gave us a number around sensitivity of 80% and the specificity of 90%. So they advise to use it in only high prevalence zone, or if the patient had an influenza like illness 2 weeks back, or even with a 1 week of history.
Right.
So they advised, to use a combination of IgM plus PCR to figure out things, because there have been some studies, and you can repeat them or advise them quarantine. But some states reported when the strategy was rolled out, and some some kits were, validated by them. But when people started getting them into practice, they were finding all sorts of results, which is normally the issue with first generation ELISAs, probably the issue in US as well.
Correct.
So now ICMR has decided to field test them again. It introduced a moratorium for 2-3 days. It will be evaluating doing a lot of tests in the field and see what it comes with. Though we have the access to antibody tests, they are pretty cheap, but then lack of specificity is a big concern.
Mm-hmm. Mm-hmm. So, but just again, to go back to the beginning and to be clear, there's no place that seems to be overwhelmed in India. The hospitals are doing okay.
Okay, so the answer is that India is quite a heterogeneous country. For example, in Mumbai, cities like Mumbai, Indore, they are starting to feel the pinch now. Possible community transmission is going on because you have slums in Mumbai, now they have been affected, and we are not getting sources of contact. So in Mumbai has been a major source. Mm-hmm. There's a city in Madhya Pradesh, Indore, that has also been overwhelmed. In between, there were cities which were involved in large numbers, but they have been contained. In particularly, the state of Kerala, it had the initial influx, a lot of patients from Dubai. So, but it was contained. Thankfully, actually, India has a culture of doing. We have a lot of people that are working on the ground. We have the manpower to run the isolation and quarantine strategies. So that also helps. And Kerala had a culture of containing, because last year we had a Nipah virus outbreak. So we had just like Taiwan, which had a culture of responding to that. So Kerala contained it, and the numbers. Kerala is almost the population of South Korea, though the GDP would be like 10 times lower. Right. But it had a culture. So it was contained in Kerala. The Kerala has managed to flatten the curve. So in India, we are,
Yeah, can you describe a little bit more specifically what that strategy is? In Kerala, in particular.
Okay.
The quarantines are public places, or?
Yeah. Okay. So it is like a China-like approach only. We adopted some of the best practices from China. That is, initially we tested all the travelers and their asymptomatic contacts at fifth to seventh day when the viral load was expected to be high. We advised initially all patients to be home quarantined, but it was not voluntary. The police was always there. You could the people and police used to check almost once or twice a day. They used to call them or personally came and checked for better compliance. Mm-hmm. For patients or for people who lived in overcrowded area, they were taken to the central quarantines. And at many places at hotspots, the central quarantine is it is enforced, particularly at the hotspots, because as we know from the China experience, the household transmission was pretty common. Mm-hmm. Then healthcare workers, if they are symptomatic, they were brought they are also quarantined. Then for every severe pneumonia which gets admitted, we have to have a COVID test. These are the guidelines. They are, enforced because in India, the state is a health subject. So states are enforcing it to various levels of efficiency. Some states are doing it better, but some states are not. But again, as you told, that we would have expected the numbers to be showing, right? If it was going into the community New York style or Italy style. But unfortunately, that is 2 or 3 weeks late. But still, and even syndromic surveillance, as US experience shows, people are doing all sort of innovation. They have, set hospitals to fill it on every prescription of Tylenol, every prescription of a cough syrup has to be reported via Google form. They have mandated the pharmacy and doctors. But again, this is state outsourcing its responsibility to private sector. And we have fever clinics in the hotspots going on, but every state is trying in its own way. In particularly the hotspots, the execution is a bit more efficient because they are first to be caught up with that.
So, central quarantines, I find it. Obviously they must work to some extent, but they must be quite a challenge also because the staff. And what about the PPE, the personal protective equipment, and not getting the staff infected and not getting this sort of perpetually transmitted in and out of the central quarantine? So
obviously central quarantines are, even it's in this challenge to liberty. People don't want to be in, so they would rather be in home, right? But some experience from China show that work. We are trying to, because most of them are asymptomatic. We just do the PCR on them, advise them, but PPEs are, since it has gone, the lockdown has given us some time, so the PPEs have been procured, but till now we have not been overwhelmed. But at places like Mumbai, it's a real challenge. Now they are, making the stadiums, converting the stadiums into field hospitals. And they are, placing the central quarantines over there for the quarantine and the mild COVIDs. So they are converting, as was done in China, because they have started getting overwhelmed there.
I'm sorry, where? So they've been quarantined in the hospitals and hostels, yeah. Or where? In the hospitals.
Okay. So yes, YMCA hostels, many hotels have been made into quarantine places. At places. And the places which have not been overwhelmed, they are, managing with primary health centers or traditional hospitals. For example, my hospital, which is a 750-bedded hospital, has a facility for 200 people for quarantine and 50 people for isolation of mild COVID. So those hospitals have been graded according to the trial process. They are the COVID care centers, which are hospitals which can also provide the ICU facilities to the COVID patients, and hospitals have been converted into COVID hospitals depending upon the level of their capability. So firstly, you have the quarantine places, which might be lodges, hotels like YMCA, they have been converted. Then you have the second grade, where the COVID hospitals take care of mainly quarantine and mild COVIDs, and other hospitals which are for COVID patients which are moderate to severe, that is, which are either desaturating, just require oxygen, right? No, but it is an evolving strategy. Every state is, enforcing it in a different style. In fact, every county is enforcing it in a different style, because In India, we have an IS system, so every system county in so the
So that's one
DM
of the
district enforcing it in a
in a
different
different
style
way,
according
right?
to the process.
Yeah. So that's one of the interesting things you find, right? That across the world, it seems like there's very different approaches being taken all over, right? Taiwan has a very different approach than Singapore, than South Korea, than India, and because India, like you said, is so heterogeneous. Kerala has central quarantine stuff, but yet, despite the fact that there's so many different approaches, it seems like all of that is buying time, I guess. My point is that does it seem to not matter so much what the individual states are doing because maybe of things related to the virus in India? I have no idea, or because of the fact that you just, because of the travel restrictions, etc. Maybe and because maybe all of India isn't as traveled to as, say, New York or something like that. You didn't have as much seating, and so you never had to deal with an initial startup of a vast number of kind of cases. But are you getting the sense of that despite every state doing something somewhat different, that the mechanics of what exactly each person in each state is doing is doesn't seem to matter that much?
Basically, as you rightly told, it is a function of the spread, is a function of viral load, the initial, which patients got in, and we all know that till vaccines come, it is going to be a long fight. So, various states are going into it at different times. For example, Kerala has contained it, now Mumbai is getting it. But still, the approach is till vaccine comes. What are your approach? You are always fending against the virus, right? What are your approaches? The approaches are simple. You try to run the contact and trace strategy by various strategies. So this is, for example, Northeast in India. Northeast states don't have high number of cases, very few number of cases till now. But again, when the virus goes into, because India has a high population density, so many people initially were advocating a test South Korea style approach in India, which was actually not feasible given our limited resources. The central lockdown did was, firstly, it educated people. People are now aware about it. It gave us time to ramp up our PPE and testing capabilities. Mm-hmm. Because otherwise, in every epidemic, even so-called dengue epidemic, even in typhoid outbreaks, India routinely gets overwhelmed. If you visit some hospital in India, what is happening in NY city is pretty common in India during right. fever outbreaks in July and August. So now, but everyone is aware about this. At least a culture and best practices. People from Kerala, the states with good functional healthcare capabilities, are visiting us. They're trying to educate us. So
do you think in Mumbai, right, in Dharavi, right? Dharavi is, you would say, one of the most congested parts of the world, probably, right? I mean, they say, I don't understand how, social distancing in Dharavi must be. I have no idea how that happens, right? I mean, once it gets in there, you look at Singapore, right? Singapore, where the recent outbreak has happened, has been in the dorms that they have, right? And the dorms that they have in Singapore are much different than Dharavi, right? I mean, my God. Yes. So yet, as of earlier today, the Dharavi outbreak in Mumbai, it's 200, right? There were total 200 cases in Dharavi, right? 25 new cases detected today, according to some reports, right? So my point is that, I mean, in the worst congested parts, where people are living very close together, right? What is it that the virus is not exponentially? I mean, why are we not having some type of New York City type approach in Dharavi? Because I mean, I'm sure not every single person in Dharavi is being tested, right? What's the population of Dharavi? Would you say 1.5 million? Yeah, something like that, right? 1.5 million in a very small, I mean, tiny area, very dense, right? I mean, incredibly dense, probably more dense, much more dense than even New York City, I would imagine. Yes. And yet, in these fertile grounds, right, you're not having the virus kind of just take off.
So Possible regions, I mean, it is very difficult to speculate in absence of widespread testing, but it is not happening in hotspots. But still,
Yeah.
Even the mortality in South Korea was also low. Our population is a bit younger. In Mumbai,
That's what I was going to
so
ask. In the Ravi, for instance, do you have I have no idea actually. Do you have a sense of, are they mostly very young? I mean, where are all the old people? Where are all the old
so
people?
people are. I mean, even I personally, because not only Dharavi, there are many cases. For example, Kolkata, that's a fairly almost 8 to 10 cities of India would have a higher, almost 1.5 times higher population density than New York. So,
Yeah.
but our population is a bit younger, like South Korea. Number two, maybe sunlight, humidity that might have some role to play in restricting, keeping down R naught a bit low, a
We're big
bit
on UV
low.
light. As
That's
of today, the UV light, the role of UV light in American consciousness has risen to the top.
Did you see? I don't know. I don't know.
plus,
Anupam, you may not be aware. Did you see the? Did you see the? I was. My head was in my hands when the press conference today. Did you see the White House press conference today or no? Do you know what we're talking about?
no, I didn't see. I heard somewhere that Trump was advising UV light and bleach to be addicted. I mean,
Here, let's go. So we'll take a. So what happened was the Department of Homeland Security has run some tests. I guess. They've run a bunch of tests. It sounded like to me like they're internally they have labs, Johns Hopkins, they're working with, and they were looking at the half-life of COVID, of the virus, in a variety of different conditions. And UV light, sun, blah blah blah. The half-life goes from 18 hours to something like 2 minutes, something like that. So the nice DHS guy said, "Oh, this is interesting and whatever," and of course, as soon as the politician, Mr. Trump, gets up there, he starts talking about, we should think about giving UV light to people. What about curing people with UV light? So,
but open air therapy started in US only, right?
Yeah.
In Boston, right?
I agree, and then I will put a link that you shared with us, Anupam, a couple of weeks ago about open air treatment for influenza. So I think there's some face value plausibility to the idea that sunlight can be helpful to reduce the spread just in and of itself.
You watch
Actually,
rates of melanoma are going to spike in 10 years.
I'll take it seriously. Every hospital of ours has shut down its AC. We have exhaust fans running all over our central quarantines. We are trying to run our OPD in open air because you think, how will a resource-constrained country manage these outbreaks? We don't have US style. Our HVAC systems even the ICUs don't have that amount of facility. So healthcare workers will get infected. So the only way I see, in addition to the tracing and contact, is to decrease the transmission. Either it comes via nice antiviral. India also advised hydroxychloroquine to all its healthcare workers, which might or might not work. But if at all it works, it is the possible right time to to cut its transmission. Then you have to keep the transmission low via these measures. For example, tuberculosis is very common in India. It is almost airborne, but still people have been working with it with minimal precaution. You would hardly see a hospital in India which had an N95 culture. How does it work? So we put masks on the people, masks on the infected people. We do have BCG vaccination, but the immunity is pretty low. It is said to prevent severe infections in 2 years, in first 2 years of life. But again, despite tuberculosis being so prevalent in India, with an R naught of 10 in untreated patients for 6 months, still you don't see a lot of people getting infected. So possibly, I mean, people have made all sort of regression equations. So possibly, I think temperature and humidity cuts R naught to maybe 1.5. Though this is not in strategy, this is luck, right? So we cannot. But I personally think ventilation is a big issue. At least I believe. I mean, I don't have evidence, but I believe, because we are always trending till the time we have a good antiviral, that even if it doesn't reduce the mortality rates, at least it cuts down a transmission. That will be our, that will be a important weapon in that war.
So when a hospital shuts down the AC system in India, can they? I mean, are they all older buildings? They can open the windows, or
yes, Yes,
Okay,
most of the
which is, it's
hospitals
not the
have.
case in many U.S. hospitals. I mean, they're completely, modern constructions, hermetically sealed, completely
But
dependent on recirculating
but
air.
but they have good central air AC systems, which I probably think would work. Even I was seeing some hospitals in New Jersey have created negative airborne rooms the conventional way. They have applied pipes to individual rooms, and they have put exhaust fans outside to
Right.
create a negative pressure room, and also put them in isopods. So we are in India till now. I mean, in absence of resources, I don't think the negative pressure rooms and everything, hardly 20% of the ICUs would have the required requisite negative pressure rooms in India. So these are the approaches we need to factor, at
So
least
there
in
may be
India.
some environmental reasons why India has been spared. I'm surprised again. What's the traffic from China? I would have assumed that there was a lot of traffic from China early on, and that you'd be caught off guard. Is that the case?
We were actively tracking the numbers from China. We were pretty cautious about since start of Jan. From 14, 15, we were screening the patients. Now, what is interesting here, you look at numbers in Pakistan, a country very closely linked with China, and still the numbers haven't shot there as well. I mean, they are high, but they're not that high. Now, Pakistan gives me hope.
Right. So even though
It's a country very deeply
even though
integrated
they
with
didn't
China,
lock down, sorry, they didn't lock down as soon as you did.
They locked a week later.
Okay.
They locked down a week later.
Why did they give you hope?
Because it is very closely integrated with China, like Italy, and still the caseload is low.
So much more so than India, you're saying?
Yes.
Right.
Because if that, maybe it's due to younger population, maybe some element of environment and immunity, I don't know. But despite being so integration with China, like Wuhan had with northern Italy, still the numbers are a bit low.
So
on
you're
the
saying
on the question of
that,
sorry, one more thing on the question of BCG that you just mentioned. There have been theories that BCGs can actually protect against COVID. Did you look at the numbers? Some people are making claims looking at Portugal that has apparently a BCG policy and Spain doesn't, and that sort of thing. I didn't look closely. Have you looked at that?
No, people have started these trials in India. There are some inactivated vaccine. It's like a man-2 test they will be doing, but I haven't looked at those numbers closely because because Indians in US and UK are also getting affected, right? Many people in New Jersey
Right.
and
Okay.
Indian origin healthcare workers. So
Sure.
I don't think immunity alone is a
right. That
good
makes sense.
thing to rely upon.
That makes sense.
what? So go back. I think we go back to this. How is it that tuberculosis in with an R naught of 10? How does India control that in places like the Ravi? I keep going back to the Ravi because that seems to be the most difficult type of.
So there are 2-3 things about tuberculosis. For example, I'll try to talk side by side about COVID also. So one, TB has a very good drug which cuts down the viral transmission, right? In 3 or 4 doses, the isoniazid and rifampicin cuts down the transmission to a substantial value. I think in India, it is very difficult to maintain social distancing. The overcrowding will always be there. The attack rates in the family second rate will always be high. So you have to have, and we advise the TB patients. They visit our TB centers. It is mandatory to visit them in India. So they are advised to wear masks. We give them good nutrition. We give them 1 month supply of anti-tubercular drugs. And in general, we advise them about ventilation practices. This is the way every person on the family wears a mask. India also had an epidemic. The epidemics have been happening long in India. So we have a culture. I mean, people place scarves on their heads and etc. Since we had a lot of plagues in India in early 19 early 1900s. So people, maybe some older generations have that memory. So people are aware about it. So maybe some of that is already in place. Regarding this COVID, so essentially similar principles would apply. In a place where you cannot enforce social distancing, either you take them to central quarantines. If you have a good antivirals, so people were considering hydroxychloroquine prophylaxis and or to all patients of uh, Dharavi. Now you might laugh at it, but this is the way essentially malaria was controlled in India. I used to live in a village for 10 years. So for every presumptive fever, they used to distribute chloroquine.
Mm-hmm.
For trachoma, for worms, the chemoprophylaxis is pretty common in India. You visit the villages. So it is pretty common. Malaria is still given presumptively. It is very common. And the anti-chloroquine, it's a part of our national program. So I was a bit surprised when people were, raising questions about the hydroxychloroquine toxicity, which is a much safer variant of chloroquine. I thought, okay, efficacy is still in doubt, but it has a lot to do with politics. In India, chloroquine is used right, left, and center, still in the village. And we have a village health guy who is no clinical background. They are giving chloroquine, and chloroquine is has much more worse side effect profile than hydroxychloroquine.
So
but we don't know the hydroxychloroquine works. So if that worked, chemoprophylaxis is a part of public health culture of
so
India,
probably what's happening is that you're giving out so much chloroquine that most of the folks are dying before they get old, and so now you have a young population that's now ready for COVID. It's hilarious because I mean it's not that I don't appreciate the cardiac effects of these drugs, but yeah, I mean so many drugs. My God, how many QT prolonging drugs that are pretty powerful do we give not infrequently under supervision here? And we don't see. We seem to do it pretty safely most of the time. And here, as you're pointing out, in India, there's some random guy in a village who's giving the drug out, and I'm sure he's not doing an EKG every day on these people.
No, hardly. People don't do ECG at all. I mean, chloroquine has a much worse cardiotoxic profile than hydroxychloroquine. Now, there was a recent EHR, a paper on Medoxy, which looked at EHR. If you are giving it alone, SCQS doesn't have that amount of toxicity, and cardiotoxicity. And if it was so much cardiotoxic, why were you giving it in SLE and rheumatoid arthritis? Okay, you are giving it for immunomodulatory action, but these people are essentially at high cardiac risk. There was also a trial of hydroxychloroquine running in MI patients in Iceland or Norway. I think the OX1 trial. I mean, it is good to be suspicious of efficacy. Till an efficacy is not established, you shouldn't ideally give a drug as a prophylaxis, and I fully agree with it. But this is a condition which has an asymmetric risk. This can kill you, even if it can kill you a case fatality rate of 3 or 4%. People in Boston and actually we got that idea from people in Boston, right? People in Boston where doctors in Boston started using it first. Obviously, there were reports from China, but people in Boston started using it as chemoprophylaxis. Then people in AIIMS and Delhi adopted it. I was taking it 10 days before the advisory came in. I'm not, defending that.
Yeah.
Obviously, the efficacy should be established. But what is the efficacy for masks, prophylactic masks? Mask is useful only to prevent transmission, right? It doesn't protect you. So anything, that is why, and some people were offended when I said that hydroxychloroquine should be given as, if it works, should be given as chemoprophylaxis. Then people were advocating all that kind of theories. But this is what it is. Chloroquine is still widely used in India. Much more toxic drug at much more high doses. I don't know.
Once Trump starts discussing chloroquine use, that's it. The media will be full of
maybe when Trump wears a mask, N95, when people will avoid wearing it, that might also happen. Now, obviously, everywhere. In absence of uncertainty, it is true. Every debate would be politicized. That is why a need for an RCT was important, maybe. But now that these events are happening in US and UK. probably the chances we'll have some results of RCTs of, I think, SCQS or, by, I think, June.
Right.
Fortunately, by that time, we would have certain amount of data.
Anupam, was India involved with the first SARS in 2003? No, not affected at all. Okay.
Even swine flu epidemic didn't build an N95 culture in India. I mean, somehow it just passed us and we were wondering how to prepare for it. Now the swine flu, the H1N1 outbreaks appear at intermittent levels with irregular intervals in India.
So Anupam, how is tell me, because I don't want to keep you for too long. What is the economic impact of this in India, of the lockdown? I mean, in India.
Yeah, it is tremendous. Lockdown impact is tremendous. Everything, almost people realize it now. It has been partially eased since 20th of April.
It has been
3 days back.
Oh, how has it been eased? What are they
eased in certain. So this is how we are developing approaches around it. So we divide a hotspot district, that is the county, based on our doubling rate less than 4 days, or it should not have an absolute number 80% of total cases. So the lockdowns will be prospectively extended in response to the data which is coming, the doubling rate and the absolute numbers. And the hotspots have a fever clinics and every intense activity going on around there. You have a containment zones. It is being in hotspot district. It is being fought on principles of war. You have containment zones. You have a lot of fever clinics, active and passive surveillance. But in other areas, traffic has started moving, and it is slightly. Schools will probably be closed for a long time. The public transport might, but some economic activity will be resumed. And that is my opinion. But I mean, it is very easy for politicians in some way to, because they are masters of everything in lockdowns. So politicians will always want to be assured, but at the same time, easing a lockdown without also has its risk. You would lose your political currency. So politicians will always want to, if lockdown is enforced, they may like to, at least it is true in India, people want to hold it for longer to be sure. But now people are realizing it will constrain our economic activity to a larger extent.
So Anupam, if you're unable to, of course, eradicate the virus, right, and the virus stays at some level, right, and you start moving around again, I mean, the idea is that all of these moves that we're doing are not aimed at eradicating things, right, because it's now out of the box. So clearly, so the question is, will this happen again? What do you think is the best thing moving forward? Like, what's a reasonable thing that you think India should do moving forward? And then, and two, what do you think the impact will be of that?
It will obviously, these outbreaks will happen once we start moving. Better idea would be to look at every district, county as its own in isolation, and that is how to plan policies regarding it rather than shutting down an entire state. That would be a wrong policy in my opinion. Plus, the good thing lockdown has done is it has built a culture. Now every doctor or patients even know. So I probably think and that the transmission would be reduced. But people will die if the lockdown is extended. People will get tired, will develop corona fatigue. I mean, they cannot. People have to eat, right? For how long they can live in their homes? I mean, that is probably the theme in US as well. Though in US, people are more aggressive about it, despite being such numbers in NY city. I mean, I don't know. But in India, we have many states which have population, many cities which have population density of NY city. So we have to be more careful. Prevention, we can go it only in a defensive posture. I understand for many states in US with much lower population density, it might be a good approach. But in India, obviously, a different approach should be adopted.
Do you think, based on what we know, that if we start moving around again and the virus is still circulating, especially in some of these mega cities, especially in slums, etc., that this will be this will result in a massive number of sizable fatality and all that?
Yes, even if infection fatality rate is say 0.05%, cut it down to half, keeping it mind our age profile and etc., it would still be absolute numbers, right? Even if you adjust for the
so you think
temperature
it's,
and not.
So you think it's inevitable that at some point in the next year, you're gonna see in India a sizable number of people that are dying?
Yes, in July to September, it is a flu season in India. So we might have a temporary quiescence in June and then followed by a surge in July or September. But I am personally hoping we might have a good antiviral. For example, Tamiflu, what it did? It didn't decrease the absolute mortality, decreased some amount of viral load and decreased length of stay. Even if I would have that certain kind of drug which decreases viral load by 30%, every one of us wears masks, we have adequate ventilation strategies. I am a bit hopeful because prevention is and source control is possibly our best bet.
Source control meaning containment.
Containment, yeah.
So you think India may be able to get by just aggressive surveillance testing, or just testing symptomatic people, and then if there's an outbreak found, just kind of containing it?
No, in hotspots they are testing the asymptomatic. They are doing random testing of asymptomatic patients. They've started random testing of asymptomatic patients as well, like they did in Italy, the town of Wo, or in South Korea. So obviously different approaches have to be adopted everywhere. It is not a disease. It is going to be with us long till the vaccine is developed. Probably it is too early to make forecasts depending on what it is going on. But it is very clear that every county, in fact, has to make a different kind of decision based on its weaknesses and strengths. One strategy won't be running. It is not advisable to run a single strategy everywhere. Though we instituted a lockdown, but I think that it was to establish a culture of testing awareness in India at least. And we stopped. We were not overwhelmed. That was the only good thing. But this thing, obviously, central lockdowns cannot go forever.
Excellent.
Very good.
Thanks, Anupam.
Anupam, it was very enlightening. Thank you very much for spending time with us before going to work.
Thank you.
We wish you the best. Take care.
Thank you.
All right. Take care.
Good night.
Bye-bye.